I want to start here with a simple quote, if you'll allow me. Developing better health and care services requires constructive cooperation with the health industry, both at a national and international level. The Norwegian government's 2018 white paper goes on to state that the government wants to take steps to improve the interaction between the health and care services and different private and nonprofit parties in the health innovation ecosystem. Friends, our hands have been forced in terms of public-private cooperation in healthcare by COVID-19. Since March, things have taken a dramatic step in what we would consider a positive direction in terms of collaboration. In fact, it's not been since March that we've been able to meet together in person, so I would like to warmly welcome all of you and thank you for being with us today. It's good to see so many people live for a change. We will see if this is able to continue. We have a very special topic and timely topic, public-private stronger together, building a resilient and sustainable healthcare system in Norway. Building upon the mentioned momentum of COVID-19 public-private sector collaboration and coming together for a common goal, and I want you to keep these questions in mind as we move ahead today. What does a resilient and sustainable healthcare system look like for Norway? What is needed to secure this vision together? What have we learned from COVID in terms of mindset and behaviors we need to take forward to support a continued constructive public-private sector approach? And finally, how will we know if we are being successful in this endeavor? We have a fantastic panel lined up. We have Dr. Atun from Boston joining virtually. I'll put him on screen in a moment. And we have 5 distinguished panelists. You see their names here. I will introduce them after Dr. Atun's initial remarks here. I'm going to try to now put you up on screen, sir. Bear with me one moment. Almost. While we're getting him on screen, sir, if you don't mind, I'll go ahead and give your brief background. Dr. Rifat Atun is the professor of global health systems at Harvard University's T.H. Chan School for Public Health. His research is currently within 2 primary areas. The first examines health systems performance and how design and implementation of health systems reforms impact on outcomes. The second research area explores the adoption and diffusion of innovations in health systems and innovative financing in global health. Professor Atun has worked with more than 30 governments globally, as well as the World Bank, the World Health Organization, and the UK Department for International Development. He has also worked with the Norwegian Research Council's Global Health and Vaccination Research Board. It is an honor to have you with us today, sir, and the virtual floor is yours.
Thank you, Jason. Yes.
There. I can see some of the audience participants here with us.
Yes. Yes.
We saw your slide for a second. There it is.
Yes. Can you? Okay.
Yep,
good.
We see it.
We are so dependent on technology. Well, thank you for this opportunity. It's an incredible privilege and honor to contribute to this important meeting. Very timely and very pertinent given the COVID-19 experience in the world. So my presentation is going to focus on sort of 3 major areas. First, I'll briefly talk about the context, then briefly visit the response to COVID-19 and health systems responses generally, and then spend some time on the opportunity, especially what the new context means for public-private partnerships. Well, I think we're all fatigued with not just COVID-19, but with the data and the numbers. But today, we exceeded 20 million cases and have reached almost 700,000 deaths. And of course, these are huge underrepresentations. The numbers are far, far greater. But what COVID-19 has really shown us is that the debates between wealth and health and wealth is no longer a debate. We've seen the impact of COVID-19 on the wealth of countries, on the wealth of individuals, health of populations, but very importantly also on social cohesion and security. So we have a complete new context where we cannot ignore health as an integral part of well-being of a country and the world as a whole. The economic impact of COVID-19 is going to be huge. Only yesterday, the UK announced the worst numbers ever on record and worst performer in the European context. And the IMF projections in April were projecting a decline of 6.1% in advanced economies. But by June, that was revised down to 8 points, and even a big decline in emerging markets. Very different to 2008 economic crisis, where the declines were about 1% globally. But the consequences go well beyond health and the economy. And we're seeing unemployment, issues around food security, even in advanced countries. Social compact is being undermined. The social attitudes to science are being crystallized into those for and those against. And we're seeing a social polarization. And this is a picture of sort of networks. So we're becoming for or against, as opposed to this sort of heterogeneous and integrated social groupings that we've had in countries. And what COVID-19 has shown us, and I think this is probably the most important message from this presentation, this is the interdependence and interconnectedness. So I think this argument about public versus private, I think that's passé. It is really not really relevant. We're all in this together. So the question is not whether public and private sector should work together. The question is, how can we make this work in a way that's going to benefit everyone and that's going to create opportunities for developing sustainable health systems that can contribute to sustainable development, social cohesion, and security in countries, but also globally. But let's look at the response to identify where we have gone wrong and where we can improve. The health system responses to COVID-19 have varied in countries, but in many countries it was ineffective, inefficient, inadequate, and inflexible. And in the European context, we've seen terrible needless deaths in countries that have had well-functioning, so-called well-functioning health systems. Now the epicenter has shifted to Americas, and we're seeing huge consequences in Latin America. And the epidemic is now moving to Africa, where health systems are particularly weak. But some countries have performed well, especially those who've had in place good governance, with strong leadership, good command chain, consistent communication, and reliance on science, with policy agility to respond. Countries that have been able to use fiscal space and budget flexibility, those that have invested in partnerships, in maintaining supply chains and scaling up production capacity, countries that have used technology for testing, tracking and tracing, and data and analytics, countries such as South Korea and Taiwan, for example. And in relation to healthcare services, we've seen that response was agile and augmented in countries that were able to use technology, but also invested in public-private partnerships and use innovations to respond. And outcomes have varied. So there are countries still going through the first wave. There are countries that experienced a V-shaped response, such as Austria, for example, in Europe, and Slovenia or New Zealand, and many of the South Asian countries. Many countries are going through this wide U-shaped response, and in many others we are seeing a W-shaped response, for example, in the US, with the second wave coming through. So there's some important lessons to be learned. But one important message, certainly for me as someone who's been working with health systems for more than 30 years, and I had the opportunity to work with more than 100 systems when I was at the Global Fund as head of strategy, is that health systems have not been able to respond to changes and transitions. And COVID has really unmasked the decline and the sheer magnitude of underperformance that already existed. So let me give you some examples. So this is a study we published recently in the Lancet that looked at management of hypertension in 44 low and middle income countries, representing about 60% of the world population. And as you can see, it's a cascade of care looking at for every 100 individuals that is hypertension, how many people have their blood pressure measured, those who are diagnosed, those who are treated, and those who are controlled. In Latin America and the Caribbean, the control levels are about 25%. In Southeast Asia, the numbers are less than 15%. Middle East and Central Asia, around 10 to 15%. In Sub-Saharan Africa, well below 10%. So health systems are not coping even with the commonest chronic condition. But you might say these are low and middle income countries. What's the relevance to advanced countries such as Norway? But actually underperformances, not just in low income countries, is pervasive. So if you look at the efficiency of health systems in Europe, this is in the European Union, compared to the efficiency frontier of what is being achieved by some countries, we can see underperformance for many countries at the same per capita health expenditure and health systems. So there's a huge inefficiency and welfare loss in health systems. There's also ineffectiveness. So I pulled just a couple of figures from OECD database and included Norway as well. These are the latest data. So for example, management of asthma. Hospital admissions vary almost 4 to 5-fold. Norway is doing relatively well. Very few admissions should be for asthma. This is a condition that should be managed in the community, at home, or at primary care setting. But in many countries, there are many unnecessary admissions, what we call avoidable admissions. The same picture with diabetes. Again, huge variation, huge ineffectiveness in the way we manage these common chronic conditions. So the systems are inefficient, they're ineffective generally, they're inequitable, and they've been not inflexible in the response. And the question is why? Well, I think the reason is because we have this innovation misalignment. This is an op-ed I did for the Financial Times a couple of years ago, where I noted that scientific developments have spurred unprecedented delivery of innovations in new medicines, new medical devices, new diagnostics, but innovation in care delivery has faltered. Not much has happened. And when saying that, I was being quite generous. So if you look at delivery of innovations, we have lab on a chip, we have big data and incredible analytics with machine learning, artificial intelligence. We're transitioning from population level health to highly precise population health and precision medicine. But in innovation and delivery, we have not progressed. So this is a picture of Hôtel Dieu de Paris, the oldest hospital in the world that is still functioning as a hospital. It was established in 651, 7th century. It's still functioning as a hospital. So the delivery models have not changed that much. And if we look at the behavioral interventions we've used to manage SARS coronavirus 2, they date back to medieval times, to 14th century. So quarantining of ships, voluntary behaviors such as hand washing, social distancing, face masks. These go back to 14th century. And it was very interesting that with face masks, there's been a huge debate whether we should or we should not be using face masks. But we didn't have the research evidence until very recently. But still, people are debating whether what type of mask, how often, where. So on the delivery side, we've not done very well. So why is this important? Because if you look at the expenditure on medicines, diagnostics, and consumables in the OECD is between 8 to 16% of total health expenditure. I've also included Norway here, where expenditure is around 8%. This is where the innovation is happening, and this is where the big debate around cost reductions, cost containment is happening. The big part, the 90 to 92%, the delivery part, where the innovation is not happening, this debate is not taking place. As a result, we have huge inefficiencies. The World Health Organization estimates that around 20 to 40% of health expenditure is wasted. So there's huge potential for improving the way we use resources that are available to us. But we need to focus on the system as a whole, not just a subcomponent, and create an ecosystem for innovation to happen. So the second reason why we have this innovation challenge is a policy misalignment. And this happens in most countries. I enjoy reading your white paper where you're beginning to address some of these issues in Norway. So on the one hand, we have industrial policies that energetically push innovation, encourage innovation, developing new industries, new technologies. But health policies on the whole constrain innovation, or they're designed to constrain innovations, or their uptake in systems. And economic policies on the whole tend to be detached from both. And also they discount from health systems contribution. So what's important going forward is to create an ecosystem where health policy, industrial policy, and economic policies are aligned to create a setting where innovation emerges, but also innovation is taken up and diffuses at scale to have population level impact. So to get to sustainable systems and to ensure security, we need to address issues of ineffectiveness, inefficiency, inequity, and inadequate responsiveness to external shocks such as COVID-19. But there's an opportunity given the magnitude of the challenges that we face and the underperformance that is pervasive in countries. So the opportunity is to develop sustainable health systems by increasing their agility, by embedding innovation into day-to-day functioning of systems, but also developing resilience. Now, and there are a number of transitions that can make this possible. The platforms are emerging. The first transition is in science, where our understanding of biology, our use of big data and analytics is enabling us to move from population-based interventions to management of subpopulations, for example, use of monoclonal antibodies or precision population health, to highly individualized therapies, such as immunotherapy or precision health, precision medicine. So this transition offers incredible opportunity in not just generation of new diagnostics and medicines, but also their application in populations at scale. The second transition, which is critically important, is the incentive systems and the payment systems that need to change. And this is beginning to happen again. So in the past, the focus on resource allocation has been very much on structures. So money followed structures such as provider institutions or inputs such as medicines or technology. But many countries realized that this approach was not appropriate, did not lead to improved outcomes or improved efficiency. So they transitioned to a functional focus where money followed activity. But again, this did not lead to the desired level of efficiency, effectiveness, and outcomes, as I've illustrated to you. But now we're transitioning to a value focus, where payment follows value. And what we value is individual outcomes, both in terms of clinical outcomes and reported outcomes and population-level outcomes in terms of health, financial risk protection, and user satisfaction. And it's very important to note that G20, the current G20 presidency, has put value-based healthcare as a priority as one of the priorities that should be shared in the communique as and when this is agreed in the next 100 days. But for this to happen, to harness these opportunities, we need to invest in people that can innovate, that are open to innovation. We need to invest in partnerships. We need to use existing platforms in all sectors, and we need to develop appropriate policies to enable the creation of such an ecosystem. Now, the current landscape for public-private partnerships is quite fragmented. So there's a lot of outsourcing going on, and these tend to focus on hotel and ancillary services, clinical support services, purchasing of medicines or diagnostics, or in some settings in European context, also even outsourcing core clinical services. But given the transitions that I've mentioned, there's an opportunity now to actually rethink the public-private partnerships to create enabling platforms for developing innovative health systems, innovative platforms in terms of data, in terms of communication, in terms of analytics, in terms of resource management, but very importantly, is an incredible opportunity for developing integrated health solutions that brings together new advances in data analytics, risk stratification, personalized care pathways with use of personalized diagnostics and medicines, and new financing methodologies to ensure that we're able to harness not just effective solutions, but also the way they're delivered to improve efficiency, but also ensuring a level playing field so that what is provided is equitable to benefit all the citizens in a country. To do that, to transform health systems through new public-private partnerships, we need to take a step back and think, what do we need to do to create this enabling context? And here I offer you 4 C's. First of all, we need to consult widely, work multi-sectorally, work with citizens, the users of the system, to jointly identify what the system challenges are for them. Secondly, challenge the current practices and benchmark performance. We're not very good at that, as I've demonstrated to you. For many indicators, we don't have good quality data. As a result, we are losing huge amounts of resources every year. In the US, for example, $1 trillion are wasted each year out of 3 trillion that are spent on health systems. Third, co-produce, co-design, and co-implement solutions, working across sectors and within sectors. And fourth, work together to create an ecosystem for innovation, both the generation of innovations, but very importantly, their introduction into systems and their rapid uptake to lead to outcomes. So this is my final slide. To make this happen, and you've articulated some of this in the white paper, the 2018 white paper in Norway, we need to bring together universities that are the hubs for science and technology with industry that can harness this science and technology and develop it further. But very importantly, we also bring health systems into the picture to ensure innovations are applied and iteratively refined and developed so that they can reach scale and they can have population-level impact. So I think COVID-19 has led to very adverse outcomes for health, economies, and social welfare of countries, as well as social cohesion and security, but I think provides an incredible opportunity for us to work together to create new forms of public-private partnerships to benefit all. As they say, never let a crisis go to waste. Thank you very much for your attention.
Dr. Atun, thank you very much for that insightful presentation. I have a lot of questions I know a lot of you have questions, and we have a rather large panel to get through, so I'm gonna hold off on my initial questions. But Dr. Atun, if I may ask you kindly to show slide 20, at least during our initial conversation on the policy misalignment. And I promise then we can go to more optimistic slides as the conversation develops over the next hour or 45 minutes. Thank you for that. If I could ask our panelists to kindly take the stage, I will introduce you briefly in the meantime. Starting with Dr. Kjetil Taskén. He's the director of the Institute for Cancer Research at Oslo University Hospital, group leader of the Institute of Cancer Research Department of Cancer Immunology, and professor of medicine at University of Oslo. Dr. Taskén's research is currently focused on precision medicine, cancer biology, drug development, translational medicine, and innovation. A warm welcome to you, sir. In addition, we have Raji Medwan, who is the general manager of Roche Norway. She has nearly 30 years of healthcare experience with a background in nursing and an MBA from the Wharton Business School. She has worked throughout Europe and the US at Roche, Genentech, and Johnson & Johnson. In addition to her day job, Raji is also the chair of the American Chamber of Commerce and sits on the board of Industry Association LMI. Erik Landstein is the Director of Government Affairs at Cisco Systems Norway. He has a background at Senterpartiet as a politician, serving as state secretary within 2 ministries, as well as the office of the Prime Minister. Yes. Prior to Cisco, Erik has worked extensively with the intricacies of public-private partnerships at both the Norwegian Ship Owners Association and the Norwegian Forest Owners Association. Welcome. Ann Tyerman is the managing director of MSD Norway. She has been with the company for 15 years, serving in multiple Brussels and US-based leadership roles. She is trained as a biomedical engineer with a PhD in applied economics. Ans too is a board member of the American Chamber of Commerce in Norway. And last but not least, certainly, Dr. Stig Slørdahl is the CEO at the Central Norway Regional Health Authority, and just recently, in June, I believe, completed his tenure as the lead of Norway's Decision Forum. He is a professor at the Faculty of Medicine and Health Sciences at NTNU, where he served as dean for 10 years. Dr. Slørdahl has been a board member of numerous Norwegian and European committees and research councils, and is a specialist in internal medicine and cardiology. I'd like to also especially thank you, Dr. Slørdahl, for taking the time to be with us and coming down from Trondheim today. Thank you. What I'm going to do now is ask that each of our panelists take a few minutes to comment both on Dr. Atun's initial remarks and introduce your view of public-private partnership. Dr. Atun, I want to thank you. I don't think I've ever had anyone kind of decimate a title of an event we were doing more quickly than when you did at the start, and the idea of public-private partnerships as being passé. You are indeed correct that we are all in this together. So, with that being said, Raji, the floor is yours. Thank you.
Thanks, Jason. Thank you, Professor Atun, and you're a really hard act to follow. And no, I didn't compare notes with Dr. Atun, but you'll see many of his themes are also on my mind. And some of the thoughts that you had really resonate with me, especially around visualizing the inefficiencies in the system. And I'll talk more about that. I think one of my observations or reflections from your presentation was how well we've done in Norway as a country. And I just continue to remain impressed. I'm sure you all are. One of the earliest countries to take action in lockdown. Yeah, and here we are, 200-something deaths are still too many. Every death matters, right? But compared to what we've observed in other countries, and if you look at our COVID numbers, I think we've done a remarkable job, and kudos to all of us in the room as the community and leaders, but also to folks like Dr. Slørdahl and others in the parliament for making some really tough tough and the right choices for us. So Jason, you have to give me the cutoff.
I will let you know.
Because I can talk
Yeah.
forever. So I'd love to start with some trends. So as I think about what we're experiencing in COVID for the past few months, I think change is a constant, right? When I look back to my days as a young child and then growing up, things were much slower. Now seems like on a minute-by-minute basis, things move and things shift and things change. So change is a constant. Technology is exploding, right, all around us. We're learning a lot about diseases, and we are going to come up with more and more solutions. So that's just a fact. If you look at research and development and company pipelines, we are just getting better at science and really going to those niche diseases and finding solutions. We know also populations are aging, so people are living longer, so more need for solutions and medicines and care. And all of this puts pressure on the system, and budgets and sustainability is a topic that's not going to go away. And even we, Norway as a rich country, have to deal with it. So we are a pretty advanced healthcare system, but we're not immune from these trends. Our oil fund will dry up one day. So sustainability as a topic, I think, is a very relevant one for us to think about as a country. So great question for the panel. What does a resilient and sustainable system look like? I had three thoughts. The first one is in keeping with the vein of what Dr. Atun was talking about. So I believe just learning from COVID, it's just brought it more really about visualizing waste and inefficiencies in the whole system, and then figuring out ways to minimize them and eliminating them. I'll give you a personal example at Roche. We for years have talked about digital signatures, but process got in the way. We talked about legal, we talked about risk, and we continued to have 50-page contracts that had to be signed in person, wet ink. COVID came along. In a matter of 2 weeks, we had DocuSign, electronic signatures. Things just fell up, out of the way. We've saved time of busy people. We've saved cost, and most importantly, we've increased the customer experience. Our customers are happier, and I'm happier as a GM who has to sign many documents. It's just quick, fast, efficient. So surely there are ways in our entirety of a healthcare system where we can look for efficiencies. And I take full accountability as an industry member here, right? So this is not just a call out to the public system. I think all of us actors have to think about the solutions we bring into the healthcare system. What's the value that they're adding, and what waste or inefficiency are they reducing or eliminating in the system? And I think with COVID, we have to really reevaluate a lot of that. So back to my DocuSign example, I think many of our tasks and our day-to-day jobs are going to change now. We don't need to travel. We're doing a lot more digital. So this is something we need to look at in the healthcare system. My second reflection was around harnessing data and really leveraging technology and digitalization for better outcomes. Once again, we've seen this in the COVID situation where day to day we are being guided by numbers and by data that we collect on how we're doing as a system. And lastly, there's something again, and Dr. Atun referred to it, around agility and adaptability. So how do we create a system that's more flexible to receive innovations, and we are able to pivot easier? I don't have the answer, but I think there are some good learnings from COVID. So we've seen many patients didn't receive care during the last few months, couldn't get into hospitals. Hospitals are stressed because of coronavirus. Doctors are tired. You worry about the risk of bringing cancer patients into systems. They didn't get care. Going forward, can we look at how do we create multiple sites for provision of care? How do we think about digital interfaces so patients don't have to come into hospital? We pharma, we bring a lot of intravenous infusions for different diseases. how do we look at our product development and see, can we bring more oral medications, more subcutaneous medications that can be given out of the hospital in a different setting? So I think these are all things that can then help us be much more agile and much more adaptable when crises hit or not. So I'll close with just a couple of reflections from behaviors that I
Raji,
believe.
if I'm sorry to cut you off there.
No, you cut me off. That's, so I'll just close.
Yeah.
And then I will keep my thoughts on my 2 pages.
We will come back to you, I
Q&A.
promise you. Thank you very much.
Thank you for your time.
Kjetil?
Oh, thank you.
Yep.
I also appreciated Rifat's talk very much. And I think, as Raji said, we managed the COVID pandemic quite well in Norway. And that has also allowed us to think about other things in the healthcare system. And for example, with cancer, we're sort of back to doing clinical trials quite early, etc. And I'd like to talk about an initiative that we're working on at present called Impress Norway, which is for precision medicine, implementing precision medicine in cancer. The acronym is for Improving Public Cancer Care by Implementing Precision Medicine in Norway. That's how the acronym came together. And for me, this started when we, in Oslo University Hospital Comprehensive Cancer Center, had a working group to see how could we sort of take precision medicine forward in the cancer area. What did we need to do to get going with implementation and align with the political goals and what the ministry and the regional healthcare authorities wanted. And we made a very simple plan. We said it was done last summer. We said we need 3 things. We need the diagnostic platforms. We need to increase the volume of clinical trials, and in parallel, we need to work with the implementation. How is this going to look in the future when it's into more ordinary clinical practice? And then when we had the plan, we started working on the different aspects, and we had also, during the course, had 2 national meetings, which were bottom-up, aligned with the political authorities and the levels above us in the healthcare system, but still it was a bottom-up initiative. How could we do this? And I think we got going. We're sort of rolling out now a network of diagnostic platforms. It's been funded by the regional healthcare systems. And then we started working on seeing, could we make a big clinical trial for Norway, which is quite close to implementation. That's the Impress Norway initiative. And in doing that, we worked with the authorities and for public funding, but we also worked with the pharma companies to see how could we sort of get together to do that. We need to use the diagnostics. We want to have a national molecular tumor board that can discuss cancer patients with advanced disease. We're putting together an algorithm to sort of select drugs. And we talked to, so far, 16 different pharma companies about their possible involvement. Not all of them are going to be involved, but it looks very much like quite a number of pharma companies are going to come together, also leverage drugs, pay per patient costs. And it'll be a national undertaking. We want this across the country. And I think in doing this, we touched on many other things that Rifat in his talk touched upon. We've had to work with people, we worked with partnerships, we built platforms, we worked with the policy or aligning with the policy. And around this, we're also trying to build a more formalized public-private partnership for precision cancer medicine. It's going to be called Connect. It will be facilitated by Oslo Cancer Cluster as a organization that also organizes the public and private partners, and that will give an opportunity to observe how is the diagnostic platforms rolling out, how that can be discussed, how is the clinical trials rolling out, how can this be implemented, how should the implementation methods be, how would the reimbursement be organized in this area in the future, because the evidence is going to be developing. There are going to be small patient populations. It's going to look different. And how are the legal aspects also going to have to develop in parallel with that? I think doing that has sort of been a very interesting exercise, and I think people really want to work together. And I think it's also it looks like it'll come together in that way as a public-private
Very good.
partnership.
And you're assembling a national board, you said, now?
Part of this is setting up a national molecular tumor board that would take referrals to discuss patients for precision medicine across Norway, and where they will have participation also across Norway from different hospitals.
Okay.
For this trial and other trials
Very good.
in the precision cancer medicine area.
Yep. And Impress is officially to be launched at sometime in early 21?
Impress, we hope, can start early 2021, but we filed an application for the public funding. There was a dedicated call for a big precision cancer medicine trial. The discussions with the pharma companies are also ongoing. So, you know, a lot of things will have to come together, but at the moment it looks good.
Very good. Very good. If you don't mind, I'm going to move on. So we're sure to hear from everyone initially here. Eric, the floor is yours.
Okay, thank you very much. The first question we were asked is what does a resilient and sustainable healthcare system look for Norway and probably other countries? And I must then, as a representative for Cisco, state the obvious. I'm sure we will use far more of video in the future. The history of Cisco in Norway is that we acquired Tandberg in 2010 for 19 billion Norwegian kroners, one of the largest industrial acquisitions in Norway throughout history. And still today, we have the business development unit for this part of our global business here in Oslo. And for us, it's been tremendous to see how fast large parts of society have changed their way of working, and very inspiring to see how large percentage of the population that are responding that these changes are at large very positive. Most of it is actually adding value to our everyday lives. And I recently heard some results from a study conducted by Accenture. They interviewed 2,700 people in 6 different countries. Out of them, 40% have experienced that they interacted differently with the health sector using new digital tools during this crisis. And more interesting, 9 out of 10 of those who have started interacting in a different way experienced this as good or very good, and were likely to prefer to continue with this. Of course, most of us would say that a physical meeting, it's, you know, our preference. 85% would say that. But in many cases, you can have the same, or in many cases, even better experience if you digitize. Your experience with DocuSign is obvious. You save time. It's at least the same quality. And for a cancer patient, it's obviously very attractive if the need to go to the hospital in times of an pandemic or in periods where your immune system is low can be reduced. And we have been discussing this with the cancer hospitals in Norway, and they are telling that they will really now consider this. But it is interesting, as Professor Rifat is pointing out, how slow we have been in innovating in the way we are delivering the health services. And I will say also it's reason to reflect also on our structural barriers to organize the whole system and the way we interact with the patient more effectively. And if I may mention one example.
20 seconds.
20 seconds, okay. We've been working with Rikshospitalet, Oslo Universitetssykehus. Doctors located in different hospitals are able to view the same information about the same patient at the same time instead of looking at the papers in sequence. The result is that the time they need to conclude on further treatment of the cancer patient is reduced from typically 6 to 8 weeks to a maximum of 1 week. And they get a much better quality in the treatment because they're able to sit down together and discuss as a collective group instead of working in sequence. And for us in Cisco, working with this hospital, developing this new technology is of course a tremendous opportunity, because not only are we doing something meaningful, but we are hoping to export this solution to the rest of the world. So.
And Norway exactly uniquely positioned to be able to do so.
Yes.
Frankly.
Yeah.
Thank you very much. Ans?
Okay, good. I will try to be a little bit faster because I don't want to repeat too many things that already been said. But so for me, the three key things that are really important to have a resilient and a sustainable healthcare system is the one that was really elaborated by Professor Atun, and is the importance of innovation. And I think that's what we are seeing and feeling now as people, as patients, as a population. We are all looking at when is the next vaccine coming? When is this vaccine for COVID-19 ready? When we will have an efficient antiviral? So we need to make sure for a sustainable healthcare system that we have a system that sustains R&D and R&D companies and values innovation. So I think that's the most important one for me. And that also means that when we invest in R&D, that there needs to be a system, a healthcare system, that looks at innovative medicines different than commodities. These are not the off-patent drugs. These are not the LOEs. These are the new inventions, and we need to make sure that we look at them differently and that we have fast access. The second one, and that's not been mentioned, but I think it's an important one, is prevention. So the best investment in a sustainable healthcare system is to prevent that people get sick. So we need to make sure a healthy lifestyle. Vaccines, really important. And today, less than 5% of the healthcare budget is invested in vaccines or in prevention in general. And I think in Norway, we are very lucky. We have a very good child vaccination program. We have very high vaccination rates, but we can do better. You know, the glass is always half full or half empty. So we have a very, very strong base, but there are other vaccines available for the childhood vaccination program, and we are not doing enough for adults. So how will we set up an adult vaccination program? How can we make sure that we prevent and that we have a system in place for when a vaccine is ready? And I think that's really, really crucial. And the third one is collaboration. And it's a very strong point in the white paper, the mindset of collaboration. What I've seen in the last months is that when there is a crisis, suddenly we can collaborate. We never had as a company so many calls with NOMA and with NIPH in the last 2 months. Really constructive calls to make sure that we had continuity in supply, that we found really creative solutions, because we had a couple of our products where suddenly there was an increase in demand worldwide that we did not expect. Like we had one product which is a muscle relaxant that normally is used for operations, but suddenly it's used for intubation. And in some countries, it just went through the roof. So we really needed to be hands-on and work not only with Norway, but with governments around the world to make sure that we were supplying real demand and not the hoarding. And we had many, many phone calls on that. So I know we can do it in a crisis, so I would actually love to keep this crisis feeling a little bit over time and make sure that we continue with this mindset.
Thank you very much, Ans. Stig?
Yeah, thank you. And thank you for the introduction. I think it's always good to have this global perspective when we are discussing. And as a former dean, I used to say when some researchers got the Nobel Prize in 2014 at my faculty at that time, I said that Norwegian research, medical research, will not be the same after that time, because it shows that little Norway can foster researchers at a global top level. And I think this crisis we have been through with COVID-19, Norwegian healthcare is not going to be the same after this crisis. We just saw with the test equipment, we were lacking that for a period. It was difficult to get globally. Within 1 week, the Technological University in Norway had developed a new testing technique, which could be produced in millions. So in few weeks, we have 5 million test equipments. Still, I think we have taken 500,000 tests in Norway. So we have a huge, and that shows something with this, what we heard in the introduction, the importance of collaboration between healthcare sector, universities, and the private sector. And we have a lot of good, similarly good examples from the collaboration with the private sector. And you were talking about virtual consultations. I mean, we went in central Norway from almost none to thousands within 1 week. I was calculating the percentage, and it was so high that I didn't dare to use the numbers. And I think hopefully this will change healthcare forever in Norway. And I think we see a lot of the examples of the collaboration with the private sector, and I think it's important for innovation. I've been working a little bit with why is payers are rejecting more than 50% of regulatory approved novel health technologies. And that's because the right evidence is not available to ascertain the value of technology. And that tells me that we have to align the stakeholders. You know, the private sector and the people working with innovation should have a close contact with the healthcare sector to see what is the needs and which documentation is needed to get approved and get into the market. So I think this alignment is very important. And from my personal experience working with ultrasound, as a young PhD student, I brought the ultrasound machine to San Francisco to introduce Norwegian technology to one of the best labs in the world. Later, of course, this Norwegian company was bought by GE, so it's now an American company. But still, it shows that and of course, my whole professional career working very closely to companies making the technology makes us able to do research that no one else could do. And of course, the equipment that was developed was suited for the clinics. So it shows the importance of this very close collaboration. I think this alignment between all the stakeholders, also as we heard in the introduction, is important. Regarding COVID-19, I'm a little bit careful about evaluating what different countries have done, because I feel we have done a lot of right things in Norway. But I think the future will judge, you know, what's the difference between Norway and Sweden and Denmark. And at the moment, I'm very careful about judging other countries' handling. But I think we should be proud in Norway for what we have done. Thank you.
Agreed, and thank you, Stig, very much. Dr. Atun, I wanted to give you a chance to kind of comment on anything you've heard here from our local panel. And then I also wanted to kind of load you with a potentially difficult question here. And after Dr. Atun has a chance to comment on it, perhaps any of you feel free. And then my colleague Marit is sitting right here. If any of you would like to ask a question at any point, give her a heads up. Time is limited, but we'll see if we can get a couple of audience questions. And so, Dr. Atun, in addition to what you've just heard, it's no secret that governments are increasingly applying limits and restrictions on medical supply chains, promoting domestic production and national preparedness. How do you see these increasingly nationalistic approaches impacting the future of healthcare systems globally? The floor is yours.
Thank you. First of all, congratulations to Norway on their really remarkable response. It's a real example of what can be done. And secondly, and to the panelists for their excellent comments, and I agree with what's been said and enjoy the presentations. Now, in relation to this issue of nationalism versus globalization, in times of crisis, we do see this sort of contraction back to sort of protecting one's backyard. But we are so interdependent and interconnected now. We need to ensure that we're able to develop local capacity and local resilience while we're able to harness capabilities around the world, because it's not possible for every country to be leading in every area. That's just not feasible, nor is it possible, nor is it desirable, because it would lead to inefficiencies. So this collaboration needs to happen not just at country level among the universities, among the industry and service delivery companies, but also across countries. This could be regional, it could be sub-regional, it could be global. So what we have to think about partnerships and collaboration with a fresh lens to ensure that we don't face the challenges that we've faced, including in the European context, where many countries close their borders and all the founding principles of the European Union went under the carpet in no time. So we need to ensure that we don't go back to these times. And to develop sustainability, we need two things. We need responsiveness. So we need collaborations to enable agile and rapid response. We also need resilience. That's going to enable longer term responses. That's the definition of sustainability, responsiveness plus resilience. They cannot be achieved just through country level efforts. It needs to be necessarily through partnerships across borders, because viruses don't recognize borders.
Right. Thank you. Any of the panelists care to comment on supply chain, national? I know, Raji, I'm going to point to you. You were very early on, right in the middle of this, with your products and machines.
Yeah, so it's a concern,
Yeah.
right? So like Professor Atun saying, crises bring contractions and protecting your backyard. So we are experiencing that now, right? There's a lot of talk you read in the papers, and that then comes to us as companies, whether it's US, it's the China bloc or the Europe bloc. So that's happening. My hope is, like Dr. Atun saying, that in the long term this goes away, because our supply chains are so globalized right now. And it's, you know, it's not a joke to in one day set up a factory that is at the level of precision that you need for some of the innovations that we bring. And the investment that's required in that is quite large, right? That's not to suggest that you can only do it that, right? So like Dr. Slørdahl was saying earlier, there has to be a balance. Some things we need to do nationally, right? There are a lot of things we need to build locally, because that then helps us with resilience. But then there are things that we should leverage globally. So to the question of this whole supply chains, my hope is that as we go forward, we soon get out of this nationalistic point of view as things calm down.
Yeah, I guess there's a lot of signal effect by larger economies too, in terms of what they're doing.
But I think just to close, what I would say is, so far in the COVID experience, we've just seen a really high spirit of collaboration, and borders have been opened up, and we've been able to work very closely with governments to make sure that supply chains have not been interrupted so far.
Thank you. Stig?
Yeah, and I think it's very important to discuss this and talk about it, because it's so easy to just think about, you know, Norway, and I think this is a test on the Norwegian heart, global heart, to see that actually when we go to vaccines and treatments, that we really share this globally. And we are so interconnected, so we don't have actually any alternative today. But I think it's the fast reaction. You see, let's do it nationally, you know, just in Norway. So hopefully this is a test on our moral.
Yeah, thank you very much.
Can I also?
Yeah, please.
So as a vaccine company, and we have actually two targets, or two vaccines in development for COVID-19. We are thinking a lot about how will we handle that. Imagine that we will be successful, and we are having the pressure on countries that say we want to be the first one, or so how do we handle that? So as has been said, this is a global pandemic. It doesn't stop at the borders, right? So one of the ideas to think about is, what about looking at first the people that need them the most? Healthcare workers, frontline workers, the regions which have the highest infection rates, people with comorbidities. And then we will need, as a company, to collaborate with organizations that span borders and governments that span borders to make sure that we have this division. So it's a really hot topic, and on the companies that have these products in development or these vaccines in development, there is a lot of pressure. And so we would definitely need to think about this collaboration on a global scale.
Thank you. Kurt Rice, the rector of Oslo Met.
Okay. Thanks very much for interesting comments and thoughts. I work at Oslo Metropolitan University, where I'm the president, and we have an extremely large nursing program among several other health sciences education programs. And I was wondering if I could ask our keynote speaker if the quest of a sustainable healthcare system, quest for a sustainable healthcare system, is something that has to be pursued only at the level of policy and regulation, or if you think that there are things that could be introduced into the education of future healthcare workers that would contribute to the quest for a sustainable healthcare system.
Thank you. Dr. Atun?
Yes, excellent question. It's very important to develop health systems. One has to take a systems view of the system. And we don't do that. You cannot have one part of the system functioning and others not. So this has to be throughout the system. It starts with education, it starts with development of professionals, and it also has to feed into day-to-day practice. So, and individuals constantly need to think, and this needs how to innovate, how to develop sustainability. It needs to be part of day-to-day culture, and that needs to start early on in one's education and career. So it is critically important to break down the silos early on to ensure that we work in partnerships, not just across sectors, but also within the health system and the health sector, which also has been challenging.
Thank you. Eric?
If I may, thank you for the question, Mr. Rice. It is interesting to see how much we focus on skills with regard to medicine and ability to meet the medical needs of the patient, whereas very much is about logistics and, as Dr. Atun talked about, ability to deliver the service in the right way. And what we have experienced during this crisis is that health personnel have needed to improvise to very large extents, because they, in a very short time, had to change their way of working. And what I think we have learned from this crisis is that we know that the future will be far more digital, and for all nearly all educations, making sure that you internalize this kind of competences in your education, not only in theory, but also as part of the practical training, will probably be important to deliver better quality, closer to the patient, involving the patient more, making sure that you as a healthcare worker are able to cooperate more efficiently with other healthcare workers and the extended community around the patient that we want to mobilize to a much greater extent than we do today. And we must say that from a Cisco perspective, that we have encountered a certain conservatism with regard to the educational institutions and the health care systems with regard to using training programs and changing from within, but also adopting what has been offered by external partners like us.
Is there an existing Oslo Met Cisco partnership?
There has been a dialogue, but it is interesting.
You guys can talk after this meeting.
We can have the,
Very good.
But it is interesting. We've entered into a cooperation with the Police Academy of Norway.
Mm-hmm.
They need to move their police work from the physical area into the digital space. This is obviously an area where they need to change their curriculum. And what we have done is not only been a dialogue partner, but actually we are providing for free some technology-neutral courses that they use as part of their education. And that's part of our CSR. And of course, this is based on knowledge that is really at the forefront with regard to how digital networks are built and what are their vulnerabilities and how to detect what's going on in them and how to ensure evidence if there has been
A breach.
A breach of rules.
Exactly.
And similarly in the healthcare sector, the healthcare workers of the future, they need to be digital.
Yeah.
And it is a tremendous transformation, both of minds and the physical environment, and the minds are the most difficult part, of course.
Exactly.
And that's why Mr. Rice is so important.
The adoption of these new technologies was one of my questions. We're quickly approaching the rapid fire time here during our panel discussion. So I want you each to take 30, but I do want each of you to answer this question, although initially it will be targeted at the private sector companies. The white paper spends a good deal of time talking about the government and its self-admitted need to be a good partner for the private sector. What do you think the private sector can do to be a better partner for the public sector? And very specific, if you have any specific examples, some self-reflection here. This event is being recorded, so I'm sure the self-reflection will be somewhat limited, but would love to hear your thoughts on that. We can start with you, Hans.
So I would say I would like to offer the same what I expect from them, and that's transparency in how the system works, what are your true issues that you're trying to solve, and how can we help, and keep a focus on the common goal that we have, right? Because very often we are in a situation where we think we have split goals, but we don't. The first goal that we have together is to increase health through medicines or to delivering the medicines and the services to patients. So I would say be transparent and let's do the dialogue.
Thank you very much. Stig?
Well, as a reference to the decision forum, after being there, I think it's important to talk together and collaborate. Yeah. Because I don't like to read in the newspapers that the people we are buying from are arguing in the newspaper about what we are doing. I think a dialogue is important. I think it's important for private sector to see the needs of the healthcare sector, and actually take an early dialogue, start early, what is needed, which documentation is needed, and then get a fruitful cooperation around that. So I think that the most important thing is having a dialogue.
Thank you.
Going on.
Thank you very much. Eric?
I think it's important that we demonstrate some sort of humility with regard to trying to understand the logic and why the public sector are doing as they're doing, and as Stig is saying, not rushing to the media and in broad terms complaining, but being specific and concrete in our initiatives. And from my point of view, what I will do with regard to this, I think that Norway should say that we will take a leading role in using video technology within healthcare, and we must make sure that the different platforms that are currently being used to facilitate collaboration via video are able to interact. No one would have today constructed different telecommunications nets where you on your cell phone were not able to call a colleague of yours that were a subscriber of another vendor's network. Of course, they need to communicate directly as we are doing on email. Today, we are developing proprietary systems. And I think that instead of being in my office, being frustrated about this, I should, in a constructive way, approach the right persons and describing this problem. So that I will do after this meeting.
Thank you. Thank you very much. Raji.
So for me, two things come to mind. One is trust, and a single-minded focus on putting the patient in the center. And that's what happened in COVID. We worked beautifully with the government. We have a large diagnostics footprint to make sure within a week, 2 weeks, Roche provided the diagnostics that were necessary. We've talked about supply chains, medicines, and such. So, and why did all of that happen? For a few hours, weeks, we forgot about our differences, and we focused simply on the patient. As a community, we have to lift it together. And my hope is going forward, and that's my commitment as a company, how can we, to build on what Ans was saying, treat every disease as a crisis? It is a crisis for the patient and the family, COVID or not. So how do we treat those diseases as a crisis and have the same mindset of trust and abundance and come together?
Thank you very much. Kjetil?
I think also to me focus comes to mind, a joint focus and trust. And I think we need to have and work to have a good dialogue and a mutual understanding what are the needs and what are the goals of the different parties, and really try to also understand what's the other parties' goals and needs. And then we need to, for new technologies and new methods, I think we also need to try to set out clear paths for where the criteria are clear. And as Stig alluded to, how do one meet the needs? And then referring to some of the other discussion here, I think we've seen some very interesting transformations in the healthcare during this pandemic. One is the virtual consultations, as Stig alluded to. And I think for the future, we need digitally competent healthcare workers, as has been discussed. We also need digitally competent organizations. And that's a different sort of level. And there are things that still need to be addressed, at least on the public side. But I think with the trust and the joint focus, we can all go there.
Thank you very much. Time here, but you remember at the beginning of the session, we asked how can we measure the success of public-private partnerships going forward? What do you see as some of the most important metrics or milestones for measuring success? 5 years now, what are we going to look back and say, this is how we're doing things vastly differently now?
I think the first measure of success is that all new initiatives involve both public and private sectors. I think that must be the way forward. It will be very sad to go back to business of the past or past behaviors. We've had a shock, we've realized that we're interdependent, we need to work together. So that's the first. Secondly, I think a very important measure of success is that we don't talk about public versus private sector, but all the stakeholders working to achieve the solutions that country or a society faces. So I think people need to be on the same side of the fence, not opposite sides of the fence. And they need to consult, they need to co-create, they need to ensure that they're able to challenge the current practices, and they need to create this ecosystem. So if in 5 years' time, when we have an update conference, we see the beginnings of or the development of this ecosystem, we can say that we've been successful.
Very good. And with that, thank you very much. I appreciate not only your participation here today, but all of you very much appreciated you taking the time, and you all as well. In a socially distanced way, you are welcome to continue any of the conversations you would like to have. Please mind your 1 meter at least from your partner here, and I think there's a cafe and outdoor seating out there. The next event doesn't start here for another half hour, so I think we have a good 10 minutes at least in this room. Thank you all very much, and have a great rest of the day. Thank you.
Thank you. Thank you.
Thank you very much, Dr. Atun.